Thank you and good morning. Thank you for this great opportunity to address the committee on several of the challenges facing healthcare in rural America and offer up some ideas for potential solutions. Now, I would be remiss if I did not take this opportunity to publicly thank our senator from Iowa. Senator Grassley has made access to quality healthcare in rural regions of our country a relentless priority. Thank you, Senator, for everything you do for Iowa and for our country. Before assuming my job at the corporate office of Unity Point Health, I was the CEO of a small health system affiliated with Unity Point in Fort Dodge, Iowa. Trinity Regional Medical Center is a 49-bed hospital, including a group of physician clinics and home care services that over the years have held the designations of a 200-bed PPS hospital, a Soul Community Hospital, a rural health clinic, and most recently, a tweener, as it participates in the Rural Demonstration Program. Trinity has formal management agreements with 5 critical access hospitals and close referral relationships with sister Unity Point metropolitan markets, including Des Moines. But possibly the most unique experience Trinity has participated in to date has been as a Medicare Accountable Care Organization, an ACO. Classified as a pioneer ACO, Trinity took responsibility for improving the quality and lowering the total cost of care for approximately 10,000 Medicare beneficiaries attributed to them in this rural Northwest Iowa community. They did this successfully and continue to do so as a next-generation ACO. It is through this work the challenges facing rural health communities, hospitals, and providers have become so palpably clear to us. The first challenge to highlight is the dichotomy in incentives that exist between those who operate under total cost of care programs like ACOs, Medicare Advantage plans, and bundled payment programs, and their rural counterparts who operate under fee-for-service, cost-based reimbursement methods. While the former looks to keep members healthy and out of the hospital, the latter is rewarded when hospital beds are full of Medicare patients. If the two groups worked in isolation of each other, this might work, but they do not. They are intrinsically woven together. The beneficiaries attributed to the Trinity Pioneer ACO move in and out of the rural facilities in the region. When regarding value-based payment models, the rural groups would ask, where do we fit in? And to date, the answer to that question has been, you don't. The policy approach has been to exempt them from value-based policy altogether. We submit this approach is not working and needs to change. Rural healthcare can fit into value-based payment models. So you wonder, is Unity Point Health advocating that cost-based reimbursement be deconstructed? And to that we answer no. We are requesting it be renovated. This brings me to the second challenge I must highlight, and this challenge is the greatest: access to healthcare services in rural areas. Bringing quality care to rural Americans comes at a cost, and the cost is distinct from the actual provision of the medical service. These additional unique costs relate to the time and the distance from major service centers, lack of comprehensive community services, and healthcare workforce dead zones. We propose the renovation of healthcare delivery in rural areas include a value-based component tied to quality medical outcomes and expenditures, and that a separate and distinct payment structure is developed for the portion of cost-based reimbursement that pays for the costs associated with access in rural areas. While our written testimony goes into greater detail how such a system could be structured, I offer you some playful do's and just one don't as we design this type of system. The do's. Do encourage the CMS Innovation Center to develop pilots that test Medicare Advantage programs designed to work in rural markets like Iowa. We see great potential for Medicare Advantage to bring the benefits of population health methods to rural areas. Do design ACO benchmarks to accommodate for the additional cost of bringing access to rural markets. And do support bills like the REACH Act that allow rural hospitals to transition to new designations designed to meet modern needs. And do continue to allow telehealth practice to extend the reach of our in-person providers. And with the utmost respect, just one don't. Don't embrace a policy that allows freestanding ambulatory surgery centers to establish residence in rural markets and cherry-pick patients by procedure, further straining the viability of community hospitals. I challenge you to find one for-profit, freestanding ASC that has an emergency room. In closing, healthcare entities are the backbone of many of our rural communities. We need our rural healthcare delivery systems to be viable. We need them to make the transition to rural healthcare access centers we know they can become. Thank you for this opportunity to share these views.